Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I'm your host, Daniel Marino. Well, we have a great topic today, one that is top of mind for many provider organizations, hospitals, health systems, medical groups, as well as the payers. In today's discussion, we're going to spend some time talking about how we can build a stronger partnership between our payers and our providers. It is no secret, if you're watching the news and a lot of the literature that's out there, the relationship between the payers and providers in a value-based care world is so critical to the performance of these contracts, to how we take care of our patients, to really serving basically the needs of the provider community. And it's a different mindset than fee-for-service versus fee-for-value as we're thinking about what that relationship needs to look like. And as Medicare Advantage starts to become more predominant with our payer-provider relationships, and in particular, how we're taking care of, say, the Medicare population, it's critical that we work through some of these challenges, that we focus a lot on collaboration. We focus a lot on reducing the administrative burdens. It's been enormous for providers. It's so critical that we improve our communication and frankly, build the trust factor. Well, in today's conversation, I have 2 wonderful guests from a consulting firm called AArete. These 2 individuals work very closely with payers and bring a great perspective to our conversation today in terms of how they can really support the payer-provider relationship. One of our guests is Dareen Ghanayem, Managing Director of AArete. Dareen, I don't think I got your name right, but I'll let you kind of chime in. And SueEllen Carroll, and SueEllen is also a Managing Director, and she focuses on a lot of payer-provider relationships. So Dareen, SueEllen, welcome to the program.
Oh, thanks, Dan. Good to be here.
So, thanks for having us, Dan.
So, Ellen, maybe we could start with you. You know, you do a lot of work with working with the payers, and I know one of the big focuses that you have is kind of creating that new relationship, that collaboration, kind of breaking down some of the historical challenges that obviously have been in place for years as we focus a lot on fee-for-service. What are you seeing right now as some of the big challenges within the payer-provider collaboration?
Thanks, Dan. Yeah, I think you kind of hit on it, right? Over especially the last 15 years or so, we've kind of built into this adversarial relationship. And the groundwork of that is a lack of teamwork, a lack of trust. I think a broad challenge that both parties are facing is workforce shortages, which is just exacerbating the issues that we're seeing.
Yeah, I couldn't agree with you more. And, you know, Dareen, when you think about what's driving the payers, especially the commercial carriers in the Medicare Advantage space, and really would love to kind of focus on that, you know, they're responsible for managing or kind of assisting the Medicare community, the Medicare population, but they also have a lot of new financial drivers, right? How does that come into play?
Yeah, I mean, look, Dan, I think the past and the history has been very transactional, right? So the providers clearly have been incentivized based on the contracts to focus on the elements of the member interactions that are reimbursable via the fee-for-service arrangement. And the payers are trying to catch fraud, catch abuse, catch maybe overbilling situations. So that just feeds into yin and yang and basically a relationship that's based on, I'm going to do this transaction in a vacuum, and then I'm going to interpret that transaction in a vacuum. And that really has led to, the way that these teams work together, or in some cases don't work together.
Right.
So what value-based payments and CMS as the federal government is trying to do is to really say, let's focus that energy on the member and health improvement, and not so much on your transactions. And I think that's really driving the difference.
Yeah, I agree with you. That's a good point. And it's really a paradigm shift, right? Moving past that transactional based model to one of really more of a collaborative based model. But, we do a lot of work on the provider side. And, as we start to think about restructuring their kind of the thought process in terms of how to collaborate, one of the questions that constantly comes up is alignment around the star ratings. Star ratings are critical for the MA plans. I know it's a huge incentive for the payers. Frankly, a lot of the providers that we work with, they don't fully understand the value of the star ratings and frankly, how the star ratings benefit them. How do you get through that?
I'm going to start that one, Sil, and it's not an easy answer, but it's almost like you've got to start chipping away at this. And how we advise our clients is, data is the universal language of business. So make sure your data tells the story, and make sure you are communicative to your provider partners on, this is the quality program. It's not my particular company's interpretation of it. It is what it is. So we have a concept and a theme here that is teach to the test. This is how you're going to be graded. This is how you're going to be scored on the member's well-being and health. So it's not a payer grade or provider grade. It's a really collaborative outcome. And the data can normalize that conversation and take the emotion out, while, just the last comment on that, being respectful that a provider is not just dealing with one payer. They're dealing with dozens.
Oh, that's a good point. Yeah.
And everyone has their own rules and processes. So you got to have some empathy with that and make it realistic. So that's also a challenge.
So, SueEllen, when you're working with the payer providers, how do you get through some of the data transparency issues? I mean, exchanging of the data, working together around the data is critical, yet it seems to me everybody is very protective of their data.
Yeah, absolutely. And just to highlight what Dareen was saying, I think we've seen the most success with truly achieving patient-centered care delivery and collaboration through data transparency, and most success achieving data transparency through good governance between the payer and the provider. So that includes making sure that we're talking about the same things, agreeing on definitions for our data, and then moving forward from there, right? The first big thing that we always see is payers come and they talk about their members, providers come and they talk about their patients. And it's important to remember that's the same person.
Oh, and that's such a good point too. The terminology, there has to be an alignment there, right? Members versus patients. I think even when you talk about the cost of care, right? There is such a different interpretation of what cost is. So yeah, I agree with you. I think the aligning on that vocabulary and the definitions around it is certainly important. But you made another interesting point, and that's really around governance. How does the governance structure, how should it come into play to foster this environment of collaboration? Dareen, any thoughts?
Yeah, I do have some thoughts on that. I think that generally you've got to normalize your vocabulary when you talk about governance. So, when you're talking about quality, you mentioned quality a bit ago, and I would say the same thing applies to concepts like risk adjustment and coding, medical coding. I mean, those words sound the same, but having different interpretations by some people on what they really mean. And some of our clients we work with, really, we need to start at the beginning with a very basic foundation of, here's what comprises quality stars. Here's the metric. Here's how it's measured. Here's how how often and what the processes we're putting the providers through. This is why we're doing it. So that levels the playing field a little bit. If that is a common, kind of vocabulary or nomenclature, and then, you have to be open. Some people like reports, and I'll look at the report offline. Some people react better to portals and dashboard views. Technology can be used as a communication tool, but it can't just be, here's a link, go figure it out.
Right.
It's got to be more than that, and it's got to be bidirectional. So
It needs to be
governance
actionable.
cannot be just, I'm going to show up and I'm going to jam what I want in my 30 minutes with you. It has to really be a collaboration, and both sides have got to come prepared to that conversation.
Yeah, I absolutely agree. And, one of the things that we say a lot of times when we're helping organizations with kind of thinking about their data, any information that you get has to be actionable, and it has to translate to really that audience. So if information is coming from the payers to the providers, it needs to translate in such a way that providers can do something with it, and vice versa. I think as we start to think about the data that, let's face it, the providers have all the clinical data, right? The payers have claims and the cost utilization data. So, again, as we start to share that, it needs to be shared in a way that actually creates a lot of strong insights and a lot of strong value out of it.
Yeah, and it has to pass the so what test, So just because you got a bunch of data, okay, well, so what? And I think that's really the intent of some of these lever pulls that I think CMS is doing with the quality program, the STARS program, and even mandates like interoperability. I really think they're trying to emphasize that collaboration, making it somewhat simpler. But it really, the cultural part of this is a challenge, because a lot of times we see people having their precious interactions together, talking about the past. What happened in the past? You sent these claims, you denied these claims. And while that's important, I really think some time needs to be carved out saying, how can we do better in the future with our present? So I think that's part of our governance challenge as well, Dan.
If you're just tuning in, I'm Daniel Marino, and you're listening to Value-Based Care Insights. We're having a wonderful discussion on building the payer-provider partnership. I'm here today with Dareen Ghanayem and SueEllen Carroll from AArete. Dareen, I want to build off one other thing that you mentioned, and it is around building of that relationship, and obviously having that information that helps to drive some change, I think, is really important. I feel like the other area that really is critical is building that trust factor, right? So we're collaborating and focusing on the things that need to occur going forward. We need to have that communication, but we need to build the trust. And a lot of times that trust comes from establishing credibility and being able to see some real results. How, in your opinion, how does the payers, have they started to build, and how have they formulated that trust with the providers? Because I think in a lot of cases, providers are very skeptical.
Yeah, I think so too, and deservedly so. I think we've started, right? I think we're, in all candidness, I think it's in its infancy when it comes to trust, because you've got to change behaviors, and the behaviors that have traditionally led to mistrust has been the fact that there are unilateral decisions on both sides, and that does impact the flow of money, and that has an emotional impact. But one of the tools is that we have as an industry is a very clear definition on what is the betterment of the patient or member, and what does comprise of health improvement, and how are those measures applicable. When you start changing a measure, when will that credit of that improvement be seen? Good quality programs within a payer can predict this, and can be a very clear, here's what you do, and if you do this, if you close that care gap, if you code to the risk adjustment diagnosis that we know is important for reimbursement, you will see change. And here's how we're going to measure that. That's, not magic science, but I think that's a really good place to start, Dan.
Yeah, I agree with you. As you were talking, it reminded me of an engagement we had a couple of years ago. We were working with it was a shared savings agreement on a small cohort of patients, and we're only about 5,000. And boy, up until this point, the provider and the payer had a really, it was not a very good relationship. There was a lot of distrust there, and so we were brought in to kind of help to facilitate that and working on behalf of the providers. One of the areas that we started with, though, was collaborating around care management on the provider side with case management on the payer side. And I'll tell you, bringing those folks together, as well as them bringing the medical directors together, was a game changer. I don't know if you guys have done any of that work, but it was a real game changer in terms of being able to move that culture towards collaboration.
It's a great method. Yes. SueEllen, why don't you go ahead and start with this one?
Yeah, absolutely, Dan. That's actually what I was going to say earlier, is that the easiest way we have found to establish trust-based governance is to focus on that care management, that utilization management, because it helps reset the payer and the provider and remind them that we're talking about the same person in the end, right? So going back to something that Dareen said earlier, it's always good for both sides to bring empathy to these discussions to help kind of reset that relationship. And from there, you can see the light at the end of the tunnel. It doesn't feel like you're just chipping away at something that you'll never see that the provider won't feel like they're chipping away at something that they will never see the end of, the payoff for. So if you can focus on one area, I would focus on care coordination first. That will also help alleviate some of the administrative burden that I know both sides are feeling, especially with the workforce shortages in healthcare today.
I agree with you. And I'll tell you, this kind of gets back to, a comment that you made, Dareen. When you bring in the clinical folks who are really focused on the patient, they don't get involved in any of that administrative stuff, right?
Right.
They're really focused on the outcomes of the patient. When you bring two RNs together, one from the provider and one from the payer, they focus on how do we need to work together. And as long as they're aligned on the clinical philosophy, in my mind, that tends to work. And I really feel like, at least in the work that we had done with this one client, it really made a difference on really building a sense of collaboration.
Yeah. I mean, look, agreed. Sharing some of that transactional information, whether it be considered burden or insight, opening up those traditional boundaries where like medical coding happens on both sides. So let's maybe talk to one another about how we're coding. Another, pretty common sense idea, I think. But also realization that you've got to incent providers so that they see some light at the end of the tunnel as a payer. You can't just say, once you receive 4 stars, you're going to get some benefit. Okay, so that's maybe the end game objective, but incentivize for improvement, incentivize for trying to remove some of the burden of the reason that authorizations are universally hated across the board. So no one likes authorizations. The patients don't like it, the payers don't like it, and the providers, but it's there for a reason. So let's talk about delegation and other arrangements where we can ease that burden and still get the objective met, which is getting the right care for the right action. And I keep going back to the clinical philosophies, and the providers are very well trained and educated on how to treat and how to identify clinical situations. But that's not always directly lined up with how the Quality Stars programs work. And it just has to be understood.
Right. And it has to be understood. And then you have to build on top of that to your point, where you have to create aligned incentives. I've said that time and time again and the program, and we practice that a lot in the work that we do. If you have the aligned incentives, it's much easier for you to create the right level of behavior that you want and see the right level of results.
Absolutely. And back to your point, I think the delegation opens up the door of, okay, you've got a system challenge, we've got a system challenge, let's figure it out together. I think that's a good step. It doesn't have to be, full delegated model, but sharing some of that transactional responsibility is a good, kind of icebreaker for this relationship.
So one thing I do want to touch on real quick, and it's kind of the elephant in the room, but it's the administrative challenges that we're seeing as a result of certainly the MA products and the commercial plans. Many hospitals, many health systems have either considered dropping out of MA or are, a few of them have already. I think all in all, if you align the incentives, it's actually a good thing for the patients and a good thing for our industry. But these administrative burdens that we're seeing is really, it's creating a lot of costs and a lot of challenges. And as you said before, Dareen, not just on the hospitals and on the payers, but on the patients as well, too. How do we get past that?
This is another tough question. I throw a couple ideas to throw out there, one of which may not be popular, but Medicare Advantage over the last couple of years, especially with COVID and some of the loosened controls, I think it's become a benefit game. So you add more and more benefits to your package, and you try to do that at a low premium or no premium offering. Are those benefits that require administration, are they really helping? Are they helping turn the knob or change the cost curve? I really think that requires some deep review to make sure that the benefits are really providing an overall win for the provider, the patient, and the payer.
Yeah,
so that's one thing administratively you can take a look at. And other than that, it really is the duplicative nature of some of these functions, where I mentioned earlier medical coding. It happens on both sides, and it's not a cheap function. So, the reason for that is kind of a head scratcher to me.
Well, and go ahead, SueEllen, you have a comment?
Yeah, I think interestingly, if you really look at the incentives for both parties, sometimes they are very aligned. Both parties, for instance, are incented to encourage primary care or preventative care. However, the approach and the kind of different perspectives lead to real differences and can lead to administrative burden, as we keep talking about.
Yeah,
right?
Sure.
So one thing that we've seen really help in that is through collaboration and discussion around, making sure that if there's a technological solution or a vendor, for instance, that the payer is bringing in as part of one of their benefits, for instance, they're engaging with their provider partners to ensure that there's not already a program and initiative going on with their partners, or that it's going to actually affect their patients, their members, the way that everybody wants it to.
I agree with you. I think just building on that, it has to come down to communication. And I've said this to a number of our provider clients. If you have a big issue with a lot of the administrative challenges, the pre-certs, you need to have some conversation. You need to have some communication around it. That's the only way to get past this. Well, Dareen and SueEllen, this has been great. I love this conversation. We clearly have a lot of work to do as an industry, bringing our payers and our providers closer together. Certainly, as we start to engage in even more value-based contracts and performance outcomes on behalf of our patients, the success of this is going to be dependent upon how well our payers and our providers work together. I'm sure, there's probably a lot of questions by our audience, and many of them struggle with this. Real quick, any final thoughts that maybe pieces of advice that you might want to give to any of our listeners? Dareen, maybe we can start with you.
Yeah, I think that today's the best day to start looking at the future. I mean, don't need to wait for perfection. I really think that starting this dialogue, which we do with a lot of our payers and provider partners, they come to us and say, we're ready to start. We're ready to really start this and not just throw out an incentive program. So I think there's no better day than today. And what I see CMS doing, and a lot of other areas are following with other lines of business, how CMS acts is they're trying to tighten this up. They're trying to tighten up the reimbursement and make it so that it is much more about outcome based and not so much fee for service based. I really do feel that way. So today's a good day to start.
I agree with you. I think starting sooner than later and have those conversations. Well, SueEllen, maybe I'll turn to you. If any of our listeners are interested in learning more about AArete, about you and Dareen, where can they get a hold of you?
Thanks, Dan. You can check out our website, AArete.com. That's AARETE.com. Or feel free to send me an email, scarroll, CARROLL, @AArete.com.
Right. Well, guys, I really want to thank you for this. I think it's a great start. As I've mentioned, I think we've got a lot of work to do, but I commend you on the work that you're doing on the payer side. As I've said time and time again, I'm a huge proponent of value-based care. I think it's the best thing for our industry. So thanks again for coming on the program.
My pleasure. Thanks, Dan. Good talking to you.
And a special thank you to our listeners for tuning in. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.